Hi, Jennifer. Hi, Jennifer.
Hi, Kate. Hi, Emily.
I don't know if Emily's joined audio
Maybe
yet.
she's just on her computer.
Yep. Okay, awesome. Thank you for doing this.
No problem. So I'm just going to go on mute and stay on, and then I'll end it when you're done. So just let me know if you need anything.
Thank you.
Or if you need me to do anything. Yep. Sorry, the computers are like really slow here.
No,
I
that's
think the
okay.
snow is affecting them.
I'm just making sure that this works okay from my iPad. So.
Okay, I'm going to go mute.
Okay, thanks, Jennifer.
Mm-hmm.
Emily, can you hear us?
Yes.
How are you?
Great.
I'm home today with the crud.
Oh,
you can't
no.
tell from my nasally voice. So I've got the gals at the office helping me out with the technological factors.
Hi, it's Amy.
Hi, Dr. Boutwell. It's Kate. How are you?
I'm good, Kate. How are you?
Very good. I think we've got one of our hospitals on the line and just waiting for the last one to join.
Okay, great.
I was just telling Emily, who's on with us from Fort Madison, that I'm actually home with the crud today. So hence the nasally voice.
Oh, well, I guess you're joining the rest of us who've had it, and I hope you feel better soon.
Yeah, I know. Joining the masses.
Yeah.
Emily, have you had much snow there this morning?
Not yet.
Not yet, huh?
No, but all the schools are letting out early, so they're anticipating that we'll get it soon.
Ah.
Yeah, we've had pretty consistent snowfall here since about 9 this morning. It's accumulating quickly, it looks like.
Oh. Well, hopefully we don't get too much until I get home.
I know, that's always the trick. That's always the trick. Well, Dr. Boutwell, I will welcome everybody again once we get our team here fully assembled. We are waiting for Ellie Shaw from Knoxville as well. So we've got two hospitals joining us today, Knoxville Hospital and Fort Madison.
Okay, great.
And they each, I think, have a couple people that are listening with them that they believe will be the ones who will actually be conducting the interviews.
Great, good, perfect. That's great.
We'll give them, I think we're just a couple minutes till 12:30 here, so we'll give them a couple more minutes to join.
Okay.
Hi, this is Ellie at Knoxville.
Well, hi, Ellie. How are you?
Good. How are you?
I'm very well. It's Kate from IHC. Do you have your team with you, or are we waiting on a couple more to join?
I have one person here. Okay, yep, we're all here.
Very, very good. Well, we'll go ahead and jump in here in the interest of time. Again, this is Kate Carpenter with the Iowa Healthcare Collaborative, and we've got Dr. Amy Boutwell, our refuel subject matter expert, also on the line here. So I want to thank both of you for joining. So that you know who's on the line, we've got a team from Knoxville Hospital and Clinics that's joined us today, and also the Fort Madison team. And so I think it would be good just so we have an idea of who is on there and what roles and if you're a discharge planner or care coordinators, etc. Ellie, would you mind if we start there with the Knoxville team?
Sure. I'm Ellie Shaw. I'm the Director of Quality and Compliance. And Sharon Campbell, Director of Nursing.
Oh, we couldn't hear that second one.
Sharon Campbell, the Director of Nursing.
Oh, great.
Great.
And we are having some internet, it's just slow internet at Knoxville right now. So we're getting into the Zoom, just so you know, but.
No problem. I don't think we have any slides necessarily to show.
Okay.
It's just more so we can record it, because I know you had a team member who couldn't jump on today.
And
Yeah,
Kate,
okay.
just so you know, my computer is also flashing that internet connection problem, so I'm hoping we don't get disconnected, but I just want to make you aware that I can't promise we're not going to get disconnected.
Okay, well, I think as long as everybody's dialed into an external line, we'll be just fine with the audio. Okay, so Ellie, I have you and Sharon there from Knoxville. Anybody else we missed?
Nope, just us two today.
Very good. And what about you, Emily, from Fort Madison?
I'm Emily Laws. I am a quality staff member and a part-time case manager. And then I have my director, Stephanie. Hi.
Hi.
Here with us. So she's the director of case management and quality.
All right, great. Emily, is it Emily and then Sharon or Shannon?
Stephanie.
Stephanie. Oh, wait, Stephanie. Okay. And Emma. Okay. All right, great.
Dr. Boutwell, I think I'll just pass you the reins.
Okay, so for those of you, Kate, can you see my screen? I tried to share it. Is that working?
I can see it.
Oh, good. All right. So I didn't put together, as we all know, our time is brief, and I'm so grateful for you to come, take the time to come on the line today. I really love talking about this, and I just pulled some slides together in case it's helpful to you as you think about how to go about doing these readmission interviews. I'll tell you that I'm a practicing doctor and I practice hospital medicine right now. And I personally just incorporate this. It's really just an extension of your initial meeting with a patient. These days we often know when a patient's readmitted, maybe the EMR tells us, or maybe we have an icon or a tracker or a list. But really, even as an admitting doc or nurse or case manager, we're all in the habit of looking back in the record. And so whether you have, tools and alerts and flags and lists, or whether it's just in the course of meeting the patients and realizing that they've been here recently, I'm hoping that you'll see this is really just a augmentation of an initial discussion. And of course, it's with a purpose, which is what I'm really hoping to convey, which is to look beyond, the transactional information exchange and really try to do a little detective work. And again, that's what, as case managers and nurses and physicians, that's really what we're here to do in the clinical encounter, is to gather information, but then really assess and put the pieces together. So what to me, the readmission interview is what opens up the wealth of actual root causes of readmissions. It helps us in our individual patient care work, but also in our readmission programming work, to remind ourselves that med rec is not really a root cause of readmission, or or non-adherence is not really a root cause of readmission. There are issues that are much more specific and actionable that we can get to if we try to go a little bit beyond those first order kind of labels and conclusions to get to the root causes. So as you can see here on the slide, really, basically, if we ask nothing else, if we do nothing else, what is at the core of this readmission interview is to to simply engage in a discussion around the simple question, what happened between the day you left and the point at which you decided you needed to come back? And honestly, that is the one question. We talk about 5 whys, and I'll share with you some script, and you've probably seen the Aspire Tool 2. Those are all what I consider, auxiliary points of information. The key question is, tell me a little bit about what happened between the day you left the hospital and the point at which you or someone decided that you really needed to come back. And so this is a little bit here on the screen, if you guys can see the slides. I really tried to kind of push beyond the Aspire Tool 2 and say, okay, what is it that I specifically say, and how do I say it? Because some people from quality, or from case management, or from other departments that might be engaged, they were, I've gotten feedback over the years, you're not quite sure how to open up this line of discussion or line of inquiry, because you don't want to make the patient feel awkward or concerned that they're back, right? So this is just, I'll just give you a quick little script. Besides that basic question, tell me a little bit about what happened between the time you left and the time that you or someone decided you need to come back. This is just a little bit more of a paragraph, I suppose, my intro to opening up the conversation. And really what we're doing is we're trying to open up a brief, focused conversation. And it really does differ from a questionnaire in that in that way. So I say something like, I see you were discharged, gee, Mr. Smith, I see you were discharged 8 days ago. Can I ask you to remember back to the day you were discharged? How'd you feel when you left the hospital? And you pause, right? Because it's at that point, Mr. Smith will be like, oh, I felt fine. Or Mr. Smith's wife, right, will hop in and say, I told them that he wasn't ready to go. And that's important. That's what we're trying to find out. And so then you pause and you get the story about how they felt at the point when they left the hospital. And then you prompt a little bit further. You say, tell me about how things went over those next few days. And you want to know, if Mr. Smith says he was feeling fine when he left the hospital, what happened on day 1, day 2, day 3 of being at home? And you want to, obviously listen, and then you want to prompt a little bit of, did you have any problems? Did you have any questions? Any issues come up with anything? And you listen, well, I was supposed to get my medicines, but I showed up to the pharmacy and they were too expensive, or whatever the case may be. And then you prompt again to ask, did you have any interaction with any doctors or nurses? Anyone from the hospital call you? Did you get in touch with your doctor? Did the home health nurse come to visit? Whatever is applicable for the patient's circumstance. And you listen again for the the story of, well, the home health nurse came, but I didn't really feel like we needed her, so we decided to let her go, whatever the situation is. Now, this is the important part also about prompting for an interaction with whatever kind of clinicians are involved in their care, whether it's not limited to primary care, as you well know. Might be the oncologist, it might be the dialysis center, it might be primary care. You say, did you, during this time, did you have any appointments, or did you need to call your doctor for any reason? And I tell you, that is where I get a lot of really interesting stuff, like, well, I was told to call to make my appointment, but the office said it was going to be 3 weeks. So, I just figured I was going to have to wait 3 weeks. End of discussion, right? And they didn't say, but I called because I was, throwing up, or whatever the case may be. So you can start to learn, how does this person or their family members, how do they navigate the healthcare system? If they had a problem and yet they didn't really adequately convey that to their primary care when they called, and just sat on their hands because they were told you can't get a follow-up appointment for 3 weeks, and thus, 2 days later, they ended up in our emergency room, that really helps shed light on a lot of things that we can address. So again, this is where you kind of pause and listen and prompt. You want to hear how, were they concerned? Were they peachy keen and then, the crushing chest pain started again? Did they try to do something and they ran into a barrier? And then I think very importantly, did they try to reach out to a healthcare provider and were sent into the emergency room instead of being managed in the community? So then after, and then I asked the last question here, you can see, which is, or the second to last question, at what point did you, and again, depending on the circumstances, at what point did you or someone else, being your wife, your daughter, your caregiver, your home health nurse, your dialysis center, your PCP, you have to kind of know the circumstances a little bit, but at what point did you or someone else decide that you really needed to come back here? And I always kind of follow that up again with, we're glad you're here. We're going to take really good care of you. But if you look back over the past couple days or weeks, do you think now, is there anything you could identify that we could have done or anyone could have done to help keep you at home after the first time you left the hospital? So again, that's kind of the long form of the open-ended prompting discussion that I try to have. So I'm going to just briefly give you one readmission story and then open it up for kind of discussions and thinking about how you guys might do this. So woman I met, this happened to be, well, you'll see what the story is. So this is readmitted patient of mine, 77-year-old, very active, involved woman. She has end-stage renal disease now and hypertension and osteoporosis. Pretty good, all things considered. And the first time she was admitted to the hospital, now here's the really interesting thing. First time she was admitted to the hospital, it was her first time in the hospital for ages. I mean, years upon years, if not longer. This woman is a tennis player and she goes to the club and she has lunches, and yes, the hypertension caught up with her and now she has to go on dialysis, but this is a big lifestyle change for her. So the first time she was admitted was to have the line placed to initiate dialysis. It was just an unfortunate set of circumstances. The line was placed, she developed line sepsis, bacteremia, went to the unit, was on pressors and had fluids pumped into her. And of course then stabilized, thankfully, came onto the floor. And within about 2 days, she herself kind of woke up, got showered, put her makeup on, had her handbag on the meal tray. You've seen it all before, right? And she was declaring herself good and ready to go home. A review of her clinical status found her blood pressure to be stable off pressors, right? So she was stable in relationship to the fact that she was just in the unit having sepsis. So she was assessed to be stable, and she, in terms of a case management assessment, she was married, highly educated. She has a PCP and a cardiologist and a nephrologist, well connected to medical services, and she wanted to go, and so she was discharged. So I met her on day 8 post-discharge when she was back in the emergency room. And I'll never forget her, which is why, again, I really want you and your team to do this, because when you interview people who are being readmitted, it really makes an impact. And again, it just really helps us get so much better at what the solutions are, because we really remember the human story here. So I met her for the first time on the readmission event. So she was in the emergency room. She was, honest to goodness, she was scared, fearful. She, after having such a active, wonderful life, she had just been in the unit, told she had to start dialysis, and now she's back again. She really sadly, very sadly, thought this was the beginning of the end for her. This readmission event was literally the definition of harm that we're all trying to avoid for our patients. But sure enough, by the time I assessed her, she had crackles up to her clavicles, 3+ pitting edema. Obviously, she was going to have to come in. So I said, just in the course of meeting her, that key question, which is, tell me about what happened between the day you were discharged and today. how'd you feel when you went home? And here's the story. She felt fine. She was glad to be going home. So there would have been no red flags at that point. Day 2, 3, and 4 post-discharge, she took to bed. She was wiped out, felt like she got hit by a Mack truck, and indeed, gave herself permission because she had been through an ordeal. Day 5, she tried to get up and get going, but she really couldn't. She was just wiped out. Day 6, she was still dragging, was starting to get easily winded. Day 7, ding, 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 she missed her doctor's appointment because she just didn't feel like going. Ding, 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 red flag, right? And finally, on day 8, with all of this tough week behind her, she knew she had to come in. At this point, a chart review, let me just say, would find this readmission, quote, unavoidable. But I hope that you'll start to see this readmission was entirely, right? Why do I say a chart review would find that this was unavoidable? Well, because her initial exam in the ED, she's hypoxic, she's crackly, she's pitting edema. Obviously, at this point, she, quote, has to come in. But when you look at the series of events that occurred, we start to find completely avoidable opportunities that where we could have done a better job. So here's again, there's never any simple answer to the story, but here's a simple, clear component to her story. I said, well, okay, I moved on. Okay, let's review your medications. And I started to say, you take Lasix 40. Do you do that twice a day? Or you blah, blah, blah. Come to find out that on discharge, she was not instructed to resume her home medications. And if you kind of remember back to the ICU and going to the floor, she was actually still recovering from sepsis and had not yet been resumed in the hospital on her home meds. She was thus inadvertently not discharged fully on her home medication regimen of 3 or 4 antihypertensives plus Lasix, right? Because she's a hypertensive ESRD patient. So obviously she needs 5 meds, and she hadn't been taking them. So here were some lessons. And again, this is what I hope you get from having these interviews is she would not have flagged a high-risk flag on that initial index discharge. She did not have a high LACE score. She was not homebound. She did have transportation. She did not feel rushed out the door. How could we have avoided this readmission? When we hear the story, obviously the clear mistake was the medication reconciliation at the time of discharge. Okay, boom, like flashing red. But to me, in transitional care, we could have potentially caught that, right? In quality improvement, we have near misses and we have harm, and we could have missed that. We could have caught and corrected her story if we had done a phone call, if we had done a check-in on symptoms with a nurse or a visitor, if we had checked in on whether or not she made her appointments, and if we had checked in via phone on whether or not she got and was taking her medications. So many opportunities in this one story where we could have caught that woman's missed medication reconciliation if we had really understood what was going on with her. So I'm going to take us back to this little script here, and hopefully you guys have seen Aspire Tool 2, and let's kind of make it, bring it to your workflow and your staff and what your staff would need to know in order to try to start having these readmission interviews. What questions or thoughts do you guys have about this?
Hey, Emily from Fort Madison. Are you there?
Yeah.
What are you guys thinking about this and how it would fit into your workflow? When a patient comes in that's readmitted, are you guys able to identify that patient right away as a readmission?
Not 100% of the time. We don't have a flag or anything like that, but as a smaller hospital, generally we recognize if the patient has been in within the last 30 days.
Yeah. Yeah, you can do that as a smaller hospital, right? You know, because it's part of case management and nursing and physician workflow, you know, as you're saying, Emily, you kind of always look back, you know, well, where were they before and where did they come from? And so even if you find out within the, you know, first day or two, in the course of reviewing the chart that they've been recently discharged, you can still have these conversations. It doesn't have to happen on admission.
Yeah.
And so, Emily, what do you think that this conversation would look like, or who on your team do you envision would be doing this interview with the patient?
So formally, the case managers would probably do this. Although I think we have some providers who are probably already doing something similar. We're just not there for that conversation.
So this could be, do you guys do like multidisciplinary rounds or anything? Or, I mean, even when you're doing discharge planning, you could touch base with the providers, like you say, hey, did you find out anything about, you know, the circumstances that brought them back? And you could try to incorporate, you know, this awareness in your planning.
Mm-hmm. Yeah, we actually have care conferences 3 times a week where we do interdisciplinary rounds, and then we try to each day have a case manager round with the providers, but some of the providers are too quick for us and get in the rooms before we know it.
Yeah, and as you're saying, you know, I mean, I do this because, you know, I mean, I pay attention to this because this is an area of interest. I wouldn't imagine that every provider's equally interested in, you know, taking the extra couple minutes. So I think one of the practices here that, you know, is for your consideration is just saying, okay, well, when my case managers or nurses or whomever or quality staff, you know, should we make it a point to try to have this brief inquiry, you know, this brief discussion a little bit more consistently?
Right.
Yeah.
So I think, Emily and Ellie, I think what Dr. Boutwell and I are trying to suggest is during phase 2 of refuel work, this is one of the key topics we're going to be discussing. And our intent with meeting with you guys today is to kind of give you some pre-instruction on how to do these interviews and see if, you know, how you think this would fall in your workflow, and if you'd be willing to give it a try for the next few weeks and kind of see how it feels, what it looks like for your staff, and get some initial kind of reactions and responses for how it worked for you and what you ended up finding out, and if you think that there's value and what exactly the value is when you do these. Ellie, what's your initial reaction to these? How do you think this would work in your guys' workflow?
We've done a couple, or just one. Mm-hmm. We've done one patient interview, but what stood out to me was I liked that you provided the actual scripting, and were we using a specific tool, Sharon? Do you know what it was? Was it the STAR or something like that? I don't remember. We were using kind of a checklist, kind of a tool. And so I like that this is it gives the scripting that's a little bit more kind of casual and conversational with the patient. And so I'm wondering if something that stuck out to me, I wonder if our doctors are getting any information, but usually we do an interdisciplinary team meeting daily. So I don't know if they are bringing any information back, if they're kind of doing an informal interview of the patient. Do you know?
No, well, we only did it with one patient. We didn't do an interview necessarily because it wasn't really appropriate with this patient, but I can see where it would be appropriate in the future to have that involved as part of the interdisciplinary round. Yeah, that's what I'm thinking too. So I think it would be easy to put into our kind of our workflow. We are a small hospital as well, so we don't have a flag to notify us on readmissions, but we're small enough that we know pretty much on admission. Yeah.
our utilization review nurse usually knows pretty much right away that it's a readmission. So I don't think, as far as timing or just knowing who we need to interview, I don't think that's going to be an issue for us at all.
So that's fantastic. And, one thing that, you see here on the script, it says you with the little asterisk. Again, one thing that, we've been taught when we admit a patient is, for heaven's sakes, we admit a lot of people who are, obtunded or intoxicated or agitated or, too honestly sick to, really talk much. And so in the course of taking care of the patient in the first, hours, it's important and essential, and it's part of our training that we would reach out to anyone who could provide us, additional information, right? So one thing that I hear a lot is, oh, the patient was, this, that, or the other thing, right? Too sick or anything. And so again, just in the spirit of coaching, I don't literally say it's the patient interview and only the patient. It's the patient or the relevant, person, including a home health nurse or the SNF, overnight nursing assistant who decided to call 911, or it's the, it's the, if you're lucky enough, it's a family member who was in the emergency room but left by the time the patient got upstairs or something. So it's who is involved in that decision to come back. And that is, I think, part of the key insight is who decided to bring the patient back or send the patient in. And so if you can't talk to the patient, or even if you do talk to the patient, sometimes it's not revealing enough, because we all know we have kind of, some older people who maybe just say, hey, they might not have much to say at all. And that happens a lot. And so it's the same thing as getting like a good history and physical, a good HPI. I want to find information enough to allow me and the care team to make a good plan of care the next time around. So it's a little bit of detective work. I hear a lot of times, oh, we tried to interview the patient had absolutely no feedback. Well, I take that to be a very important signal. The patient is a passive actor in their care. If a patient's been readmitted umpteen times and yet they have no comment on what could possibly have helped and no insight as to what happened between the day of discharge and the day of readmission, then that's a signal to me that we're not dealing with a very engaged patient. So I always find some value. Again, this is me. I'm obviously a convert, but I always find some value to the interaction, even if it, quote, doesn't reveal anything. Does that make sense?
Yes.
Okay, so this is Kate, and do you gals think it's such that for at least the next couple of weeks, even if it's not the way that you decide to permanently integrate this into your workflow, while you're kind of learning about this skill and about this strategy, if you can kind of try and collect some information or have the same one or two people attempt to have this conversation with your readmitted patients over the next couple of weeks. And then I think what we'd love to do is have the opportunity to connect back with you and see if you had some some things learned as you did the first one or two. And I know you're both from smaller facilities, so it's not like you've got patients necessarily readmitted every day. But hopefully you have a chance or two to try this out. And then certainly if there are things that you've learned, we'd love for you to work with Dr. Boutwell to integrate kind of your thoughts and learnings into the phase 2 webinar when we come to this particular topic.
You can see me write simple ask. We can incorporate it into our next webinar, which Kate and I would be really excited to do. And even if you came back and said, we tried and we're just still not sure this is, we're getting a lot of actionable information, we don't need you to tell us, something that you didn't experience, But it would be great if you could do a couple of these, and would love to learn, what were the stories of your patients.
Right. And even gals, if you came back and you said, you know what, we gave this a whirl and here's what we learned. We learned this and this, and so moving forward, we're going to go about it this way. Or, it could be some things that you learn as far as how you're going to go about it, or who you're going to involve, or timing, or workflow issues, or how you're going to aggregate those things and actually bring them back to your readmissions teams and make them actionable. And anything that you learn, just the fact that you're willing to give this a try. And certainly if you give it a try and you say, gosh, I wish we could talk to them again, or I'd like to send a quick email and ask them how they would have addressed this, do that, and we'll try and provide you some feedback over the next couple weeks. I'm going to check in with each of you, and you guys can let me know your thoughts. Emily, can I start with you?
Yeah. I think that sounds great. We were just kind of talking, since we are smaller and we don't always have a lot of readmissions, we were even thinking about implementing this and trying to do with maybe patients who were an acute readmission but were an observation readmission, or patients who return to the ER within a certain amount of time.
Yep, absolutely. You'll learn some really interesting things from all of that. Yeah, so it doesn't have to be inpatient to inpatient. It can be kind of a little broader. Were they here? Did they leave? And did they come back again within 30 days? So I would think that would be just fine.
I love that idea, Emily. Great thoughts, because it will also just give you more frequent opportunity to, I think, practice the skill. Just like anything, it's a skill set, getting good at asking the questions and listening for the answers. So awesome thoughts. What about you, Ellie?
Yeah, I agree. Maybe trying to do some of these in the ER for those kind of returns might be a good idea. We'd have to see how that would fit in our workflow. But overall, I think that we'll try it for a few weeks and see what happens. I think we could learn a lot from the process.
That would be great. Yeah.
Well, I think
what
Kate. I'll plan on doing is just circling back with the both of you here. Let's see, the 28th is our next webinar, so maybe the beginning of the following week. I'll give you guys a couple weeks to get your toes wet here, and then I'll check back in with the both of you. Does that sound okay?
That sounds great.
Dr. Boutwell, do you have any other closing things you'd like to say? I'll let you wrap up.
No, just thanks so much for your interest, and I'm glad you've kind of already looked at the Aspire tool or the STAR tool. It all came from the same person. That would be me. So if you hate them all, that's what we're just trying to make this a little bit easier, a little bit more relevant. And so this is my personal PDSA cycle. So I really just appreciate your engagement and your testing and your feedback, because I want to make this better for teams like yours and others. So really appreciate your efforts and your feedback. I hope this is helpful, and you let me and Kate know if you need any help along the way. I'm more than happy to hop on another call to support you.
Thank you both for getting on the call today. We really appreciate it. You guys have a good week and stay warm.
Thank you. One last thing, will those slides be sent out?
Sure, I'll send them off to Kate right now.
Okay, thank you.
All right, sure thing.
Thanks, guys. Bye.
Bye-bye.